We are back with Dr. Caldera, and he has agreed to talk to us about some congestive heart failure things that our CHP program may notice when they are seeing patients. So there are a lot of things that y'all have asked that you, questions you forwarded to us that you want to hear Dr. Caldera's take on, so we're going to approach some of those now. Let's talk about when you talk about damage to the kidneys, is there a particular lab value that you're looking at?
So in general, the way I would see is that when you manage the volume status of the patient, you're going to have the heart in one end and the kidney in another end. So if the patients are retaining a lot of fluid and they have congestion in their lungs and they have lower extremity edema, their kidney function most of the time will look at its best. They will look like they are having appropriate kidney function. When you diurese that patient and you make them dry to remove all the fluid, then the kidney function will look worse. It's not that the diuretic is causing a toxicity in the kidneys and is making the kidney to look worse. It's simply that you have diminished the perfusion pressure that is going into the kidneys and the amount of volume that is going into the kidneys, and the glomerular filtration rate is diminished. So get used to play with the creatinine. Many of my patients with systolic heart failure have to live with a creatinine between 1.5 and 2. And that's where they live in order to be dry. Because remember, if your heart is stiff, you may not be able to manage a normal volume. If you manage your normal volume, then you are in congestion because your heart is stiff. So you need to be drier than normal. So you're going to have to accept some abnormality in the renal function. As a rule of thumb, as far as the creatinine is below 2, I am comfortable in most of the patients. When it becomes more than 2.5, then we may be getting into an area where now they may develop hyperkalemia or they may develop acidosis because of the renal failure, and then we may be more prudent. But where to put the patient is an individual decision. But in general, as far as the creatinine is below 2, I think it's a good rule of thumb that you are okay with the diuretics and you could go up a little bit on them.
So the creatinine is the key tool that you're looking at to assess the kidney function. And you said that frequently we'll see creatinines rise after being put on heavy diuretic use.
Correct.
And what I got out of that was you're essentially lowering the preload to the kidney, if
Correct.
you will, which decreases kidney perfusion, and therefore your creatinine can rise a bit, but you wouldn't necessarily take them off of an ACE inhibitor or lower their diuretic until it gets above 2.
Correct.
All things other being equal.
Correct.
Okay.
So if you are getting severely dehydrated, then the ACE inhibitor could be an issue, because in the setting of significant dehydration, the ACE inhibitor could cause some acute renal toxicity. So, but I would say that you're in a safe land as far as you're below 2, as a rule of thumb.
And if you see a patient, and we'll talk more about this in a little bit, but if you see a patient who has gained, say, 10 pounds, and they're starting to have, normally they're able to get up and go to the restroom, walk out to the mailbox to get their mail without symptoms, but now they're having symptoms, and they've gained weight. But their creatinine is still below 2, you're probably okay increasing the Lasix in that patient. Okay.
So at that time, I may not push the ACE inhibitor or the beta blocker. At that time, I will focus in their fluid management. So I will give them more furosemide or Bumex, if that's the loop diuretic that it was used. And I may, keep them in a low dose of the spironolactone. Once the creatinine is above 2, then spironolactone becomes a little bit risky because it may increase the chances of hyperkalemia. And titrating the ACE inhibitor may be a problem because also you increase the risk of hyperkalemia. So if they are hypertensive in that setting and I need to treat something, I will probably increase the beta blocker if I can, which is not going to mess with the potassium or with the creatinine.
Well, and let's talk a little bit more about that. So we talked about you don't want to use the ACE inhibitor if they're, in broad general terms, creatinine is high. So that is, and the reason is that the ACE inhibitor obviously is working on the kidneys to help control fluid level. There's another reason you have to worry about ACE inhibitors also. So if you notice that their potassium is elevated. So you see a patient with a potassium in the mid-5s to even 6. no other symptoms, the ACE inhibitor may be an issue. Is that right?
So two drugs you're going to be paying close attention to the potassium for hyperkalemia.
Okay.
One is the ACE inhibitors or ARBs, and you may not want to be titrating those if the potassium is more than 5 or closer to 5. And two is the spironolactone. So you have to be very careful about the risk of hyperkalemia. Now, you may, if you're giving a high dose of a loop diuretic, then you are running into the risk of hypokalemia. And then that's when I said before that I may combine the loop diuretic with a spironolactone in trying to maintain that potassium level. But it is precisely in patients who have abnormal kidney function, let's say a creatinine more than 2.5, and they are not in dialysis, where you may favor the use of another combination of vasodilator, which is hydralazine and nitrates. And this has been a study, one of the first studies before we use ACE inhibitors, this is what we were using. And there is a benefit, but ACE inhibitors are superior. If the renal function is abnormal, you should use hydralazine and nitrates in systolic heart failure as a medication to prolong survival in these patients, and they are neutral with regard of the potassium. They will not affect the potassium level. If the patient goes into dialysis, chances are that you should put them back in the ACE inhibitor.
Because what's it going to do? Kill the kidney?
Correct. And the benefit of the ACE inhibitor in the heart is significant and is superior than the vasodilator. So if you don't want to send somebody in dialysis because they have abnormal kidney function and then you put them in an ACE inhibitor, but once they're in dialysis, the cardiac benefit is superior if they are back in the ACE inhibitor.
So you mentioned, I guess then if you see a patient on hydralazine and nitrates, that's an indication that either for whatever reason they couldn't tolerate those medications or they were on those medications and the disease progressed anyway.
Correct.
So those are likely to be patients with more severe disease.
So if somebody with systolic heart failure, if they are in nitrates and hydralazine, option number one would be that they had advanced advanced kidney failure, and because of that they were put in those medications. Another option is that they have underlying coronary artery disease, and that's why the nitrates are being used. The hydralazine would not be used in that scenario. It would be only the nitrates. And I would say those are, and if they are hypertensive, let's say they're having significant hypertension, although they are in a maximum dose of an ACE inhibitor, maximal dose of a beta blocker, the fluid status is managed properly, then you need to add other agents for the blood pressure. And the first line in that scenario is probably the use of dihydropyridine calcium channel blockers. Something like amlodipine could be used, nifedipine could be used. Cardicen and verapamil should not be used because they cause further systolic dysfunction. And then you could also use nitrates or hydralazine. So let me step back a little bit. If you have systolic dysfunction, calcium channel blockers are not recommended in general. You don't want to use Cardicen, you don't want to use verapamil.
Okay.
But if you are forced because the patient is hypertensive, you could use amlodipine, you could use nifedipine. They are neutral. They are not harmful. But Cardicen and verapamil are harmful in the setting of systolic heart failure.
So one thing we see a lot of is the use of essentially calcium channel blockers can do two things. One, you mentioned, is from a pressure control standpoint. But the other use for them is rate control. So when you're looking at completely different disease now, atrial fibrillation or SVTs, and you mentioned the dihydropyridines. Can you just discuss briefly the differences classification-wise, the dihydropyridines and the non?
So basically the
and what you would use them for.
So the Cardicen and verapamil have a potent AV blocking capacity, and they are the non-hydropyridine calcium channel blockers. So they do cause AV block, and because of that, they will decrease the ventricular response in the setting of atrial fibrillation. But they will also decrease the contractility. While the dihydropyridine calcium channel blockers are primarily vasodilators, so they work in the periphery, and they don't do that much of AV block, and they don't do that much of decreased contractility. So it's really, there are 4 of them are calcium channel blocker, but they belong to different families. So the dihydropyridine calcium channel blockers are primarily vasodilators, while these others are primarily AV nodal blocking agents and decreased contractility agents.
So we typically see the cardizem, the verapamil used for rate control things, so AFib.
Correct.
Whereas the other two, okay, perfect.
Although cardizem and verapamil can also be used for hypertension, but this is primarily in individuals that do not have systolic dysfunction.
Okay.
Any calcium channel blocker causes fluid retention, and hydralazine causes fluid retention. So if the main symptom of your patient is ankle edema, then you're going to have a problem using amlodipine or Procardia or hydralazine, because all of them could cause peripheral edema. So it's something else to consider.
Okay. The problem with Lasix and kidney failure is twofold. You can theoretically get into trouble with the Lasix can cause some kidney problems, but also if you have kidney trouble, the Lasix may not work at all.
So, yeah, that's a problem. So, and that's when you may switch. Sometimes patients are not responding to Lasix, and you change it to another loop diuretic, and you give them Bumex, and they may respond to it. So 1 milligram is equivalent to about 20 milligrams of Lasix. So you could, if you were using 20 milligrams, then you use 1 milligram.
How do those? What's the difference in those two medications, Bumex and
So the mechanism is about the same, but I don't know if it has to do with absorption rather of the medication in the intestine. We see that sometimes you develop tachyphylaxis to one agent and then you respond to the other. Combination of diuretics, the use of saroxylene in top of the Lasix as a combination is a potent diuretic mechanism, but it will cause significant hypokalemia. So whenever I combine saroxylene with Lasix, I know that we're going to need potassium supplementation. And again, as I said before, the combination of Lasix and spironolactone, I use it, but if you're having renal failure, spironolactone is out of the picture. So sometimes patients will respond more to a combination of 2 diuretics rather than a higher dose of the same type of diuretic. So in general, the thiazide diuretics such as hydrochlorothiazide or chlorothalidone are no potent diuretics, and they are primarily antihypertensive medications. And when you look at their mechanism of action, they become more vasodilators than diuretics in the long term. So I usually don't use hydralazine as a diuretic in somebody with congestive heart failure. Hydrochlorothiazide, I meant. I would use a loop diuretics, I would say Bumex or furosemide, that you could combine with saroxylene to have potentiation of the diuretic effect. And then you could consider spironolactone if the renal function is normal.